First of all, thank you very much for your kind invitation. It's a pleasure for me to be here. I would like to briefly introduce a few concepts of a biobank, and please consider this presentation as a talk, so you can interrupt me whenever you think it's appropriate to, and to ask questions whenever you think that it's needed. The first few concepts that I would like to stress is that biobank is not a static process, meaning that there is a constant evolution in a biobank. And you can realize that starting from the ELSI problem that will be introduced later. ELSI is changing constantly. You can realize that also from the way we collect the material. You can realize that also from the fact that according to the different project, the biobank will collect different samples. So it's difficult to define a biobank in a very static way. We can say that the biobank should be modular in many ways. And I will try to explain you later on why it's needed to be modular. It's also important, beside the coding and the anonymization, that is one of the needed aspects, to have a sort of advisory board that will define if the biobank is working in an appropriate way, and to have a sort of an evaluation of the work that the biobank has done. This, I think you know pretty well this kind of situation, and I can skip this slide. Just to briefly mention the differences between a therapeutic biobank that has completely different needs, and a research biobank that it's a biobank in which you are collecting material for research purposes. And from now on in my presentation I will just discuss about a research biobank, mainly focusing on rare disease biobank, because that's the work that we are doing in Bologna. Well, for the research biobank, you can grossly determine a big difference between the genetic biobank, in which you are collecting genetic material, and tissue biobank. These are the general purpose of the biobank that are sort of very general, and these are something that is more specific for the rare disease. And as you can see, the point of the rare disease biobank is it's collecting rare materials. So you need to have the possibility to collect as much material as possible for this patient. This introduces also the aspect of recollecting material in time. Usually, as I was mentioning yesterday, rare disease patients are sort of chronic patients, meaning that since they are births, they are chronic. So they have to come to control every 6 months when they are kids, every 12 months, 18 months, 24 months. And sometimes it is necessary to recollect material, not every time, to every control, because that can be too much invasive for the patient. But it can be important to collect material at the different stage of the growth, for instance. Because you can evaluate differences in hormonal level, for instance, or you can have many differences in the what you are collecting. Meaning, if you want to run a metabolomic study, you can start also collecting different biospecimen. Another issue that is typical of the rare disease biobank is that you need transnational collaboration in order to make sense of the numbers. It's difficult with limited number to make good evaluation of what is happening, so it's really worthy to have collaboration between different biobanks. But this opens the question to how the samples are collected, so quality control, and also high need of training on how this material will be used, because these materials are precious. This is the big vision and mission of our biobank, of our registry. Sorry. The registry is a collection of information on a specific group of patients. And why am I putting together and am I mentioning the registry in a biobank presentation? We think that for the rare disease field, it's essential to merge registries in those cases in which you will have a registry for a specific disease and the biobank. Because if you have good quality sample, that is the biobank, but you don't have good quality information on the sample, then this sample can be of a limited use. And that means that for good quality, I mean a good amount of information, meaning not just the very basic information, possibly, and also updated information, meaning that you need information that are sort of following the lifespan of the patient. So much so, if you will run any kind of evaluation in a specimen of a patient, you can, in a way, discriminate between patients that have a specific, let's say, clinical outcome from patients that have a completely different clinical outcome. And usually this is the case for the registry, and especially for the disease-oriented registry. That's why, meaning this slide explains what I was just introducing, meaning that in a biobank it's important to collect, we were mentioning at the beginning, information on the natural history of the patient. That's why biobank is not a static process. These are part of the information that we should collect in a registry, and that also could have an impact in the sample that is collected in the biobank. For instance, also in a registry it's important the quality. So we can say that the registry has this specific situation. I hope, yeah, it's working. If you want to observe the course of disease and understand the variation in treatment and outcome, these are very important information for the sample that you are collecting in your biobank. In a way, association of data, merging of data, I would say it's a key word for any, if you want really to collect a good information that can provide you good information also for the analysis that you will run. So, in a way, what we can say is that if you consider a biobank and the registry, you will have common action, like collection, storage, retrieval, and distribution of the, in case this is sample and slash information. And there are similar problems that are healthy, the way you find money for sustainability of both. How do you share? What kind of politics do you have for sharing and distributing? What are the policy for quality and standardization, and also the protection? It's very similar. So what we are trying to collect in our registry, and then what we are trying also to provide for any sample that we are providing is the clinical information, but also some imaging, because, or information on the imaging, because, sometimes with the recent development of the imaging, especially if you consider the 3 Tesla imaging, you can have also information on metabolic status of the tissue that are there. Omics is, I would say, quite obvious, is getting more obvious. But also the family history data, how the disease that we are discussing is present in the family history of the patient that is coming to our observation. And obviously, all this kind of information goes as a relevant information connected to the sample. These are the data that we are trying to collect for most of the sample that we have in our biobank. This seems to be the very critical part, information collected during the follow-up visit. It's critical because if you want to really have this kind of information, you need to involve clinicians. And as you might know, clinicians are very busy, and they might not be willing to provide you all the information that are needed. And that's why we have a research nurse that is going with at the follow-up visit in order to collect all the information that will go in the registry and then in the biobank. You can also extract information from the medical record with the problem of interoperability, meaning that we don't have a single system for the collection of the medical information. So it's quite difficult to get all the medical information that are needed. This is easier for the biochemical analysis or the lab test because there are 3 to 4 systems that in a way that you are collecting this kind of information. So it's much easier, in a way, to collect those data. Imaging, and this is the kind of information that we currently are putting in our registry. Also X-rays, that is typical for most of our patients. We are dealing with skeletal rare disease, so imaging is important. Ultrasound, we are using ultrasound to control the patient. You can have the normal X-ray, but you cannot ask to the patient to have an X-ray every 6 months. So we are putting in place ultrasound protocol in order to test and evaluate how the disease is progressing for this patient. CT scan when it's needed. With the last technique, the amount of X-rays that you are getting with the CT scan is very similar to a plain X-ray. And we're also working on MRI, and especially on the 3 Tesla MRI, because this evaluation will provide us also metabolic information, meaning information on the status, on the metabolic, on the activity status of the bone and the cartilage of the patient that we are evaluating. And obviously, we are also working a lot on next-generation sequencing, whole exome sequencing, microRNA. We have a collaboration with an institution in Florence that is very active in proteomic and also in ultrastructural evaluation. But these are, I would say, ultrastructural evaluation is not so frequent, to be honest. We are also collecting the pedigree of the patient, and not only the family history, but especially the medical history of the family, meaning that we are trying to collect also all the medical record, or if not all, the most relevant medical information from all the relatives that we are working on. And this is the main problem that we are working on our institution, that is sample traceability. And I will talk to you later about this. If you pull together all this information, clinical, imaging, omics, pedigree, and all the quality information related to the sample, you will get to the point of the big data. Meaning that this is an enormous amount of information, meaning big data was born for the evaluation of astrophysics or the physical experiment, meaning all the kind of experiments that are run at the CRN in Geneva. And it's quite obvious that the amount of information that are running for a single patient is nothing compared to the information that they are collecting. But it's important to see that we are switching from the 3 B's that was variety, volume, and velocity to variety, volume, velocity, value, veridicity, meaning is it truth or not, and variability. And if you pull together all these requirements, you will realize even more that biobank is not a static process. Because if you want to go to variety, volume, velocity, well, that can be static. But value, veridicity, and variability are issues that are completely changing according to the request that you are placing for the value, how you are placing your request for veridicity, the different requests that you can ask, that is variability. In a way, we are going in a world of volume, big volume of data and evaluation of big volume of data to value. From the big volume of data, you have to extract the value that is necessary to give strength to the sample that you are collecting in your biobank. And this is just an idea of the platform that we are developing in our region. We will have a regional network that will allow us to evaluate big amount of data, not only from our institution, not only within Europe, but also this will also allow collaboration between institutions that are located in different countries. Because the network of the big data is a network that will allow you, for instance, the experiments that are done in Geneva on the nutrients or whatever are evaluated in Bologna, and the results are sent in Japan. And this is in real time. So if you think that this is the kind of networking that is already in place for this kind of data, it's easy to think that we can merge information coming from different centers and also the rare disease with limited number can become not so rare, and the number can become less limited than they were before, if we will be smart enough to collect the data in an homogeneous way. This is a brief explanation of what we are running in a project, a BBMRI project. Later on, you will get an explanation of BBMRI. I didn't want to tell you about BBMRI in this presentation because otherwise it will last forever. But what we are trying to set up in ADOPT is exactly that. It's a project of BBMRI. It's exactly the merging of the information between the registry and the biobanks. And this is getting so interesting that another research infrastructure, that is Elixir, is willing to set up a pilot on this issue. Just to tell you briefly the result in our institution. We decided in our institution we have 6 main biobanks. And we decided to set up a group of interest, meaning that all the people that were working in the 6 biobank are meeting once a month with a clear agenda and with clear purposes. And everything started September 2014. We defined to set up a mapping of the different processes that were running in all the 6 biobanks. Then we ran an analysis for 3 to 4 months, and we were able to define that one of the most critical issues was the traceability of the sample from the surgical room to the biobank, or from the day clinic to the biobank. This can sound strange in many ways, but if you think that Bologna is not so different from Istanbul during the summertime, and if you leave your sample at 40 degrees in the car for 10 minutes, that is the time that you need to go from the main building where the surgical theater is to the research building where the biobank is located, then you can get a clear view that that sample cannot be used for specific purposes, but can be used only, for instance, metabolomic is gone. You can use that for genetic analysis for sure. RNA, forget it. So, I mean, there are clear implications on the sample. And we decided to have this kind of procedure well established in order to define what was the main project. I will show you the consequences also of this result. Then we defined to have a common informed consent between all the 6 biobanks, because previously there was just 6 different informed consent, and you can, for some patient, you can have 2 to 3 informed consent to sign, and that is too much for a patient. And it also is too much for a physician to explain them why they have to sign 3 different informed consent. And then we are now running a SWOT analysis on the other main failure or main problem that we can have in all the 6 different biobanks. This was the original point of the network, and these are the activity that we were running in the group. As you were mentioning, as I was mentioning before, we had a big working group on traceability of the sample. this also regards not only the transferring of the sample, but also the management of the sample within the biobank. We have another working group on the informed consent that has already produced a common informed consent. And we are also starting a working group on literature and training. And this working group is just started, but we are sort of providing all the information to all the people in order to go to the right courses. This is the evaluation that we have run in the traceability, for the traceability and the sample management. Sorry, this is in Italian, but these are the different biobank. This is the time in which we set up a sort of a form in order to get all the information. And according to this information, we were able to place a request to our Ministry of Health for a financing. And now we will have a complete traceability of the sample with the logger. And you will know exactly how long the sample was out of the biobank, meaning from the timing from the, let's say, surgical room to the biobank, what was the room temperature, how was the sample conserved, and how long it took to the technician to manage the sample before being deep frozen. This is another product that we were able to set up, is that a common informed consent. And these are the 6 biobanks that are part of our network. This is our biobank that is part of BBMRI ERIC. It's also part of BBMRI.it, that is the national node of BBMRI. And it's also the referral biobank for the physician that are working within Teleton. Teleton is a private charity that is providing funding for research in rare disease. And we are the biobank that is sort of the referral point for those physicians that are willing to collect sample on rare disease. This is implying a lot of work because we are not providing them just as support, but there are research groups that are asking us to collect their sample. This is the SWOT analysis that we are currently running since February this year. Sorry, this is in Italian, but we are going for weakness and strength. And after weakness and strength, we are going for opportunity and menace. What can create us problem. And according to this SWOT analysis, we will program the future activity of our group within the Rizzoli Institute. We are also working an external content analysis, meaning what kind of problem or what kind of opportunities are present externally, and what kind of possibility will come out in order to provide to the biobank all the resources to survive. This led us to the decision to set up a sort of a business plan for our biobank, because it's important that a biobank is also thinking not only on quality, not only on providing sample, but also on how to sustain the biobank. Just to go deeper in the aspect of the quality issue. we are running an analysis to identify the optimal storage criteria for blood sample and for DNA. This is also part of the reflection that we are running in order for the sustainability. Meaning that if you set up a huge system of the cold chain that is not necessary, you are losing money. So we're trying to define, do we really need a huge cold chain system for all our sample? Phase 1, and these are still preliminary results, it's pretty clear that for the blood, the optimal storage is 4 degrees. So we don't need ultrafreezer for the blood. That saves us a lot of money. It's also important, and this is vice versa, we can say that freezing is sort of damaging the blood. So it's much better not to freeze, to snap freeze the sample. It's also relevant for us to know that we have to minimize the timing of room temperature for all the blood sample that we are getting. This has a very simple consequence. We are providing small refrigerator like hotel mini bars in all the day clinic, so that as soon as you get the blood shot, you will have your blood preserved in this refrigerator, and then somebody will come later to collect with a refrigerated sack to collect all the blood sample and to provide them to the biobank. This simple operation has increased the quality of the extraction in a very relevant way. We were not imagining that. DNA. The idea was to store all the DNA at -80. In reality, we can see easily that it's much better to store DNA at -30. So we are now not investing in buying new -80, and we are now going to buy -30 that are cheaper and easier to manage. This information were applied also to the transport protocol. The protocol on how the sample were accepted, and the long and short-term conservation protocol for the sample. This can be relevant not only for saving money, but the quality of the DNA and of the blood that we were able to get can increase the results on identification on this molecular marker, pharmacogenomic, and also NGS diagnosis. We are now running a different study, and we don't have preliminary results. We have very preliminary results yet, that are on the quality of the DNA after conservation of the DNA for 10 years, 5 years, 3 years, 1 year. And it's clearly decreasing. But so if you are running an NGS evaluation on a 10-year sample, you should expect a result that may be not so interesting, not just because the NGS has not worked properly, not just because maybe there are not genes that are mutated, but possibly also for the fact that the quality of the sample was not enough to provide you the right result. So this affects a lot also the selection of the sample to go for specific experiment. We were discussing in Barcelona with Ivo Gatt. They are running the same experiment, and they have very similar results. For instance, we were able also to collect information on the quality of NGS studies, and it was funny because we had a certain amount of quality, then a strong decrease, and then the quality was going up again. And we were sort of looking why for 6 months. The sample that we were preserving did not have enough quality. And we were able to get back and to find out that they were providing, the farm, the company, was providing to all Europe a stock of reagent that was not good enough. So, if you run an analysis in 10 sample of that period, the analysis will be forced. And this seems to be, let's say, not relevant information, but in reality, quality of the sample and quality of the information are really relevant also for the quality of the result of the analysis of all this issue. And that's why biobanking is really relevant. Thank you very much for your attention, and I'm open to any question.